Bismillahirrahmanirrahim. Assalamualaikum and hi everyone. I'm Muhammad Rafiki Ehsan, a pain medicine fellow from USM. Today I'm going to talk about the non-opioid analgesia. Before we are talking about the non-opioid analgesia, let's see the WHO analgesic ladder. As we can see here, there is a transition from the original three-step analgesic ladder from step 1, step 2, and step 3, which is you have to follow the step accordingly from the step 1, step 2, and step 3, and to the revised one, WHO, 4 steps ladder, which means there is the additional step in step 4, which is the invasive and minimally invasive treatment. And this updated WHO ladder was published last year in 2023, and we can see there is a bi-directional approach, which means you can start from the step 1 into the step 4, or you can start from the step 4 initially downward to the step 1. Okay? Okay, for the non-opioid analgesia, as we can see here, there is a lot of analgesic agent that we can use for the acute and chronic pain. On the other hand, other journals classify the pharmacological option for pain management into non-opioid analgesia, opioid analgesia, and others which is we call as a adjuvant because it is not act as an analgesia per se. It is act as an antidepressant, for example, benzodiazepine group like diazepam, as an anticonvulsant like gabapentin and pregabalin, as a local anesthetic, and also corticosteroid. This diagram shows different types of analgesia that act on the different sides. Let's say, for example, in the cortex, we have anticonvulsant, antidepressant, and acetaminophen. In the spinal cord, specifically in NMDA receptor, we have ketamine. For the calcium channel, we have gabapentin and pregabalin. And in the primary afferent, we have local anesthetic like bupivacaine and lidocaine. And the sensory nerve ending in the peripheral side, we have NSAID. Okay? Now we go to our topic today, non-steroidal anti-inflammatory drug NSAID. Before we want to know about NSAID, we have to know the prostaglandin pathway. It is started from the membrane phospholipid, and this membrane phospholipid will be converted into arachidonic acid by using phospholipase A2 enzyme. And this arachidonic acid, it goes into both pathway. Either it goes to the leukotriene pathway using a lipooxygenase enzyme LOX, or it goes to the cyclic endoperoxidase pathway using a COX or cyclooxygenase enzyme. And this cyclic endoperoxidase will be activate the thromboxane A2, prostaglandin I2 or prostacyclin, or it widespread into the prostaglandin like prostaglandin A2, prostaglandin F2 alpha, prostaglandin D2. This prostaglandin is important for the pain pathway. This diagram shows another COX pathway. We have COX-1 and COX-2. And we have non-specific inhibition of COX, which is aspirin, which is irreversibly inhibit the COX-1 and COX-2. Or we can have a non-specific NSAID, which is irreversible, that inhibit both COX-1 and COX-2, like indomethacin, ibuprofen, diclofenac, naproxen, nambuton, and we have a specifically COX-2 inhibition, means only block this COX-2, which is reversible like celecoxib, paracoxib, and valdecoxib. When NSAID is used, it will inhibit the thromboxane A2 and prostaglandin. This prostaglandin is useful for the reduce the pain threshold, increase the vascular permeability, vasodilation, inflammation, and pain. And for the thromboxane A2, it is useful for the powerful vasoconstrictor and platelet aggregator. But bear in mind, this NSAID also will convert the phospholipase into the LOX pathway, leukotriene, which is a powerful chemotaxis, and also bronchoconstriction. That's why NSAID is not good to use in patient having asthma. This table shows the classification of NSAID into the non-specific COX inhibitor, preferential COX-2 inhibitor, and specific COX-2 inhibitor. And this is all of the example, okay? We can classify the NSAID according to chemical structure like these types. Or we can classify according to acid derivative and non-acid derivative like this one. Prolonged use of NSAID has multiple adverse effects according to the system. As we can see here, for the cardiovascular system, you can have hypertension, exacerbate heart failure, thrombotic event. So it causes the risk of thrombotic. That's why the NSAID is not suitable for patient having ischemic heart disease. For the respiratory, so you can have a bronchospasm, angioedema, even can exacerbate the asthma. For hepatic, prolonged use will cause the hepatitis. For GIT, will cause the gastropathy, gastric bleeding, esophageal disease, pancreatitis. For hematological, can increase the intraoperative bleeding due to platelet dysfunction or can cause the dermatologic event like urticaria, erythema, multiform rash. For the genitourinary, you have renal insufficiency. CNS, it can cause the headache, hearing disturbance. For the skeletal, may potentiate to inhibit the bone growth, healing, and formation. And it also has a pharmacological reaction or drug-drug interaction between the albumin-bound drugs. Okay, when you want to know about any drugs, I usually advise my junior to use this mnemonic CPR dump. So C for classification, P presentation, R route, D dosage, usage, U for usage, mechanism of action, and pharmacokinetic and pharmacodynamic. Let's start with aspirin. Aspirin classified as an aromatic ester of acetic acid. Its presentation as 75, 100, 300, 600 milligram tablets in variety of fixed doses combination. The route only oral. The dosage for adults is 300 to 900 milligrams 6 to 8 hourly. And aspirin is not recommended for children under 12 years old. The usage is a lot. We can use for treatment of pain, mild to moderate, for anti-inflammatory, antipyretic, prevention of recurrence of MI, the prevention of graft occlusion after cabbage, for treatment of preeclampsia, prevention of transient ischemic attack, TIA, and also as a DVT prophylaxis. For the mechanism of action, aspirin acetylates thereby inhibit the COX enzyme which convert the arachidonic acid into cyclic endoperoxidase, thus it preventing the formation of prostaglandin and thromboxane A2. This prostaglandin involved in the sensitization of bifurcatin receptor to the noxious stimuli. It also inhibit the LOX pathway by action on hyperperoxy fatty acid peroxidase. This aspirin also inhibit the COX irreversibly in platelets but not in the endothelium. Okay. For the pharmacokinetic, we have to talk about the ADME, absorption, distribution, metabolism, and excretion. The absorption aspirin is very rapid, completely absorbed from the upper GI tract, has a high bioavailability 70% due to extensive first-pass metabolism. It is a weak acid with a pKa 3.5. For the distribution, aspirin is rapidly hydrolyzed to salicylic acid. And this salicylic acid is 80 to 90% protein bound in the plasma primarily to albumin with the volume distribution 9.6 to 12.71 is very high and the drug has only limited ability to cross the blood-brain barrier. At the therapeutic doses, this aspirin 50% of salicylic acid is metabolized to the saccharide in the liver via a saturable enzyme pathway, and further 20% is metabolized into salicylphenolic glucuronide, which is also a saturatable pathway, and it goes to the first order kinetic into salicylate glucuronide in 10%, gentisic acid 5%, and urinary excretion of this aspirin 15%. So initially, this aspirin will goes to the first order kinetic. When it is overdosed, it goes to the zero order kinetic. For the pharmacodynamic, based on system CVS, aspirin has minimal hemodynamic effect on normal doses. However, the platelet aggregation is inhibited and bleeding time is increased by decrease in thromboxane A2 production because it inhibits the thromboxane A2 production. For the respiratory system, these therapeutic doses of aspirin will increase the oxygen consumption and CO2 production by uncoupling oxidative phosphorylation. But bear in mind, if it is overdose, it may lead to hyperventilation, pulmonary edema, and respiratory failure. For the CNS effect, this analgesic effect of drugs appears to be exerted by both central and peripheral mechanism as antipyretic and can be manifestation by inhibition of prostaglandin synthesis at the hypothalamic level. So aspirin also increase the gastric acid production in the stomach, and the genitourinary, the drug may cause proteinuria and increase the number of renal tubular casts appearing in the urine. And for the metabolic, blood sugar tends to decrease with low doses and increase with high doses of aspirin. Okay, there is also the transient elevation of serum urea concentration and elevation of liver enzyme with the aspirin. That's why for children less than 12 years old, it can cause a liver injury or have a transaminase. It also cause a lipogenesis to decrease, and very large doses of aspirin will stimulate the steroid secretion. Aspirin overdose is very significant. It encouples oxidative phosphorylation, thus will increase the oxygen consumption, then increase the CO2 production. Initially, the minute ventilation is increased, but when aspirin levels are greatly increased, so the respiratory center will be stimulated directly, causing respiratory alkalosis. But for children, the respiratory center is depressed by rising the aspirin level, so the metabolic acidosis occur earlier, so that the mixed respiratory and metabolic acidosis is more common in children. The features of overdose of aspirin: usually patient will be conscious initially, then become unconscious in massive overdose. Patient will sweaty, having a tinnitus, blurred vision, tachycardia, pyrexia, hyperventilation, initially respiratory alkalosis, and subsequently metabolic acidosis. In rare cases, usually the patient will have a nausea, vomiting, epigastric pain, oliguria, GIT bleeding, acute pulmonary edema due to capillary permeability, coagulopathy, hypo or hyperglycemia, encephalopathy, and unconscious. In patients with aspirin overdose or salicylism, will usually present as a mimic like meningitis or pneumonia or patient in sepsis, and the treatment is activated charcoal, forced alkaline diuresis, hemofiltration, or hemodialysis. The idea of alkalinization is to increase the pH. So in the lower pH, it favors the non-ionized form which diffuse into the tissue, which is more toxic and cannot be concentrated in urine. When we do a alkalinization or forced alkaline diuresis, there will be higher pH that favors ionized form, which less tissue penetration, which is less toxic and trapped and excreted in the urine. Okay. Reye syndrome. This is why I said the aspirin cannot be given in the children less than 12 years old because it can cause the fatty liver with encephalopathy and characterized by diffuse mitochondrial injury with high mortality rate. Next is diclofenac based on CPR dump. C is a classified, so the diclofenac is classified as a phenylacetic acid derivative. It presents as a 25, 50, 100 milligram tablets or 12.5, 25, 50, 100 milligram in suppository, or in ampoule. It contains either 25 milligram per meals or 75 milligram in 2 meals and used for injection. For the dose, adult oral dose is 75 to 150 milligram per day in divided dose. For rectal dose is 100 milligram, usually administered at night, or maximum 150 milligram over 24 hours for tablet. And it also can be given as a pre or peri-operatively. The intramuscular dose is 75 milligram once or twice daily. The pediatric dose is 1 milligram per kilo in 3 divided dose. The intravenous dose is 25 to 75 milligram up to 150 milligram. The usage of diclofenac is various usage. We can use for rheumatoid arthritis, osteoarthritis, musculoskeletal disorder, ankylosing spondylitis, gouty, renal or biliary colic, dysmenorrhea, minor post-surgical pain, as an adjuvant of systemic opioid therapy, as an antipyretic also, and also to inhibit the perioperative mysis and post-operative inflammation in cataract surgery. The mechanism of action is diclofenac is a non-specific COX inhibitor, so it inhibits COX-1 and COX-2 in 1:1 ratio, which convert the arachidonic acid to cyclic endoperoxidase, thus preventing the formation of prostaglandin thrombosin A2 and prostacyclin. As we all know that prostaglandin is important that involved in the sensitization of peripheral pain receptor. And this drug, diclofenac, also inhibit the LOX pathway by action on hydroxyperoxy fatty acid peroxidase. For the pharmacokinetic ADME, absorption of diclofenac is well absorbed when administered by all routes with the oral viability of 60%. This distribution of diclofenac is 99.5% is protein bound in plasma predominantly to albumin, with the volume distribution 0.12 to 0.17 liter per kilo. This drug crosses the placenta in animal model and enter the synovial fluid in the maximum concentration 2 to 4 hours after the peak plasma concentration, and it remains in the synovial fluid up to 12 hours, okay, before being eliminated with a half-life of 3 to 6 hours. The metabolism of diclofenac, it goes significant first pass metabolism, principally in the liver by hydroxylation and methoxylation to phenolic metabolites, with subsequent conjugation to inactive glucuronide and sulfate metabolites. These two phenolic metabolites have biological activity, but it's much reduced compared to the parent drugs. For the excretion, approximately 65% of these dose will excreted in the urine and 35 in the bile, with the less 1% is excreted unchanged. The clearance is 26 ml per minute, with the terminal elimination half-life in the plasma is 1 to 2 hours. In pharmacodynamic, diclofenac causes less gastrointestinal damage than aspirin and endomethacin. It also causes dyspepsia, nausea, bleeding, mucosal ulceration, perforation, diarrhea, and may lead to disease exacerbation in patients with Crohn's disease and ulcerative colitis. It also increases in ALT up to 50% of patients. In respiratory system, it causes bronchoconstriction and esophagia. In GIT, gastrourinary is a plasma renin activity and aldosterone concentration reduced in 60 to 70%. In metabolic, diclofenac interferes with the neutrophil function, so the drug reversibly inhibits the platelet aggregation, but it does not affect the bleeding time, PT, plasma fibrinogen, or other factor like factors 5, 7, and 13. Osteoblast activity is inhibited in animal study and in vitro. Now we go to the specific COX-2 inhibitor. As we all know, the classical NSAID will block the both COX-1 and COX-2, while the selective COX-2 inhibitor will inhibit only the COX-2. So this will inhibit the prostaglandin that mostly found in the macrophage, synoviocytes, endothelial cell, brain, kidney, and reproductive tract. Because we don't have much time for the selective COX-2, I will give just an idea. So the first one is a calecopsib or Celebrex. This presentation is 100 mg tablet, but now we have 200 mg tablets. It uses in the chronic pain associated with arthritis. The maximum dose is 200 mg BD. It's a show efficacy in the post-operative setting with the COX-1 and COX-2 ratio inhibition in 1 in 30. But there is a contraindication, especially in the ischemic heart disease, having a cerebrovascular disease, mild heart failure, and peripheral vascular disease. For the pharmacokinetic, Celebrex reaches peak plasma concentration after 2 to 3 hours, with the elimination half-life of 8 to 12 hours. Mostly is 97% is protein-bound with the volume of distribution 5.7 liter per kilo. It metabolized by hepatic cytochrome 2C9 to inactive metabolite. So any drug inducer or drug inhibitor will reduce or increase this plasma concentration of Celebrex inside the body. And it has sulfonamide group, so it's very cautious use for sulfonamide in allergy. Next is a valdecoxib and parecoxib. Parecoxib is a prodrug that need to converted to valdecoxib once administered. The plasma half-life is 20 minutes and has no action on its own. The valdecoxib has been withdrawn due to dermatological side effect, while parecoxib still remain because there is no dermatological side effect. The COX-1 and COX-2 ratio is about 1 to 61. The parecoxib is a parenteral COX-2 inhibitor and should be reconstituted with 0.9% normal saline. The initial dose is a 40 mg, either is a IM or IV, followed by 20 to 40 mg 6 to 12 hourly, up to the maximum 80 mg per day. Pharmacokinetic, parechosid converted to valdecosid by enzymatic hydrolysis in the liver. It doesn't influence kinetic for renal impairment. The dose should be reduced when co-administered with fluconazole because of enzyme inhibition, but no adjustment necessary for ketoconazole or midazolam. Plasma half-life for parechosid is 20 minutes, but elimination half-life for valdecosid with 8 hours. So patient with hypersensitivity reaction can have severe reaction like exfoliative dermatitis, Stevens-Johnson syndrome, toxic epidermal neuritis, and angioedema. Last, we will talk a little bit about acetaminophen or paracetamol. The acetaminophen will metabolize in the liver into pheaminophenol. This pheaminophenol will convert into AM404. This AM04 mainly act on both the brain and the spinal cord, like COX receptor, opioid receptor, and other receptor. Because it is act on the brain and spinal cord, it has a moderate analgesics and also antipyretic properties. The analgesic effect because of the central analgesic effect that is mediated but through the activation of descending serotonic pathway, while the antipyretic action is due to inhibition of prostaglandin synthesis within the central nervous system by inhibition of COX-3, which are a COX-1 variant. At the spinal cord level, it has been shown to inhibit the neurotransmission by an NMDA receptor, substance P, and nitric oxide pathway. Acetaminophen presented as a 500 mg tablet alone or in combination with other opioids. The suppository preparation contains 1 to 5 mg and 1 gram. For pediatric elixir contain 120 or 250 mg in 5 ml. The IV use usually in solution of 1 gram or 500 mg in 100 ml. Dosage if less than 50 kilo, you can give 50 mg per kilo with a maximum dose of 60 mg per kilo per day. For pediatric dose, 15 to 30 mg per kilo, then reduce to 10 to 15 mg per kilo every 4 hourly with maximum dose of 90 mg per kilo per day. Pharmacokinetic is well absorbed from the small bowel, has a pKa 9.5 with the high bioavailability of 80% and less protein bound of 10% and large volume distribution. It metabolized by the liver mainly to glucuronate conjugate, but also to sulfate and cysteine conjugate, and actively excreted in the urine and only small fraction excreted unchanged. The N-acetyl P-aminobenzoquinone or NAPQ is a highly toxic metabolite of paracetamol. It produced in a small amount of following therapeutic doses, but is rapidly conjugate with hepatic glutathione to render it harmless. This is the flow for pathogenesis of acetaminophen overdose. In the normal condition, the acetaminophen will be ingested and absorbed in the duodenum, and it will be metabolized in the liver into sulfonation, glucuronation, and by cytochrome 450 into NAPQ, which is the toxic metabolite. This NAPQ will bind to the glutathione and quickly form a non-toxic metabolite to be easily excreted renally. But in case of acetaminophen overdose, this sulfonation and glucuronation pathway is saturated. So it goes to the NAPQ pathway and cause the accumulation of the NAPQ in the body. When there is accumulation of the NAPQ in the body, it circulates through the blood and indirectly stimulate the vomiting center in medulla. So in the stage 1 of acetaminophen overdose, the patient will have a nausea, vomiting, and anorexia. When there is an accumulation of NAPQ, further binds to the hepatic protein, so increase the NAPQ concentration that cause the cellular stress, so it causes the hepatic necrosis. So it comes to the stage 2 of acetaminophen overdose. So there will be increase the ALT, AST, increase the INR, there is a pain in the abdomen, and lastly, it goes to the extensive hepatic necrosis, will cause the fulminant hepatic failure, so the patient will come to you with the jaundice, hepatic encephalopathy, coma, even death. Again, this is acetaminophen metabolism. So by conjugation into glucuronation, by conjugation also into sulfate, which is both are non-toxics, only small amount, but about 5% will go to the NAPQ, which is a toxic. And glutathione will bind to the NAPQ to produce the non-toxic form of the NAPQ. So this is the rules of the N-acetylcysteine. When we have a lot of NAPQ is produced, the hepatic glutathione become exhausted, so it's free to form covalent bond with the sulfur hydride group of hepatocyte, resulting in cell death and centrilobular hepatic necrosis. So the treatment, we should give the patient oral methionine or oral or IV acetylcysteine and acetylcysteine to replenish the hepatic glutathione. This methionine will enhance the glutathione synthesis, while acetylcysteine or N-acetylcysteine will hydrolyze to cysteine, which is a glutathione precursor. But the IV form is preferred because the patient usually have a vomiting. Other than that, we can give activated charcoal within 1 hour of injection, and we should give patient with the fluids and antiemetic. This is revised Rumac-Matthew nomogram for acute injection of acetaminophen. The x-axis is the time, the y-axis is the acetaminophen blood concentration. So when there is cross this line, so you should start the patient with the treatment. But practically, we should give the patient an acetylcysteine as soon as possible to prevent further deterioration. So this is the table for clinical dose of NSAID and kinetic data of the NSAID. So we already finished the non-opioid analgesia classification. So you can go through for other adjuvant for analgesia options. I think that's all. Thank you and best of luck.